Bueno, buenos días, buenas tardes, estimados colegas, dear colleagues, good morning, good afternoon.
Good
Bienvenidos a
morning, colleagues. Welcome to the seminar, Building a Better Immunity, a Road Towards Healthy Longevity, part of the seminar of virtual seminars of life course.
Building a Better Immunity, a Pathway to Healthy Longevity, part of the webinar series on building health throughout the life course. Mi nombre es Carolina Homer, soy la asesora de curso de vida, abordaje integrado, y hoy tendré el placer de moderar este seminario virtual. Tenemos con nosotros hoy un grupo de expertos quienes han aceptado compartir su conocimiento y su experiencia en este tema tan relevante como es la inmunización con una perspectiva de curso de vida. Espero que todos ustedes encuentren este seminario no solamente muy interesante, sino que sea una oportunidad para generar conocimiento y estimular discusiones más profundas en este tema. Bueno, antes de presentar a nuestro primer grupo de ponentes, quisiera compartir algunas instrucciones de la plataforma con ustedes. Hoy tendremos traducción simultánea al español, portugués e inglés. Para acceder al idioma de su preferencia, pueden dirigirse ustedes a la parte inferior de su pantalla. Allí encontrarán un icono en forma de globo. Si hacen clic allí, verán las opciones para seleccionar el idioma de su preferencia. No vamos a tener una sesión de preguntas y respuestas abiertas, pero pueden usar el chat para publicar sus preguntas e intentaremos responderlas allí. Gracias, Brenda. Puede retirar el slide. Ahora, permítanme tomar algunos minutos para presentar nuestro primer segmento de ponentes. Brenda, ¿podrías poner, por favor, el slide? Las palabras de apertura estarán a cargo del doctor Enrique
The
Vega,
opening words,
quien es el jefe de unidad de curso
head
de
of the
vida de
unit
Life
of
Course.
the Healthy Life course,
El doctor Vega va a proporcionar estos aspectos clave sobre lo que entendemos
key
por el enfoque
sources of what we understand the life course approach for immunization, which will give us a framework to understand from the life course approach what we're going to hear from the speakers and experts today after the opening session.
We will have a very interesting presentation by Dr. Roy Phillip, who is currently the adjunct professor of neonatology at the University of Limerick School of Medicine in Ireland. He is the former clinical director of maternal and child health. Dr. Phillip, areas of interest include breastfeeding of premature infants, maternal vaccination, life course immunization, health services, development, and pediatric high dependency of cares. Entonces, sin más demoras, es un gusto
With
para
no further ado, it's a pleasure for me to give the floor to Dr. Vega to hear the welcoming remarks of this virtual seminar. Dr. Vega. Thank you, Carolina. And thank you all, especially all the speakers for today. As Carolina mentioned, they're all researchers, professional researchers of a very high level who have been kind enough to join us in this effort to continue to promote the life course approach in the region of the Americas. PAHO, in this effort, has promoted the topic through a publication which you have, Building Health in the Life course, and it has generated a series of seminars which will help us go into greater details of many of the aspects that this approach has in the public health practice, as well as in the organization, development, and strategies of the health systems. This effort, we have to recognize, between the immunization life course units has been working for several years trying to work together and understand what it means to develop an immunization strategy with a life course approach. Dr. Cuauhtémoc Ruiz, as well as that was our boss before the current one in the immunization unit, Dr. Daniel Salas, have all paid a great deal of attention to this topic. Now, why do we speak now of immunization with a life course approach? For all of us, undoubtedly, there has been a process of growth and extension of the survival of more than 20 years of life expectancy in the region of the Americas, where undoubtedly immunization has had a key role in the distribution of mortality, particularly in the first years of life. Now, it's not enough to have survival. This is something we all know. We consider that the life course approach can deepen the role or strengthen the role of immunization, to consider immunity as a recourse for health and the possibility of evolving better for people and populations, for which we have to understand immunization from a different approach. It will mean new challenges, and we need to understand these challenges in order to apply them in a more coherent and consistent way. Immunization, we feel, is able to maximize the healthy life course trajectory of people and in populations, and capable of protecting populations in important transitions. And in order to double these effects, we need to understand how we accomplish the different principles of the life course approach in the design process of strategies to achieve better immunity indices. I believe that the implementation of these processes has advanced incredibly in recent years and will have enormous implications in the work developed by the countries in the region in the context of immunization. This seminar, as has been said, has considered all the different aspects of immunization in the life course approach, and we're sure that the speakers will define principles in the immunization process that will allow us to achieve or find examples in the application of and benefits of this approach in the medium and long term. I hope that what you hear today will be useful to you and will lead to a positive impact in the way in which countries apply the life course approach in the work with immunization. Thank you for your opportunity to be here. Thank you for joining us. Thank you to the speakers. And I give you back the floor, Carolina. Thank you so much, Dr. Vega, for your comments and for this wonderful message, which will help us understand in greater depth what we'll be hearing from our speakers today.
I would like to invite Dr. Roy Phillips, who is going to make a presentation titled Building Better Immunity Across the Life Course and Why It Matters. So Dr. Roy, the floor is yours.
Good morning and good afternoon to everyone. Thank you so much for inviting me to share some thoughts from Ireland to PAHO. It's truly an honor and privilege to share some of our thoughts with you all, and particularly from someone in a pediatric background talking about life course. But still, let me see whether I could make some sense of it to connect the baby to the rest of the life. So if
Dr. Phillips? I think we lost Dr. Philip. Let me see.
Can we move the slide and try to...
Dr. Philip, can you hear me?
Carolina, I believe he lost connection or his internet
Okay, thank you,
connection
Fernando. All right,
is frozen.
so yeah. So if you don't mind, maybe we can go to the next presenter and just switch while Dr. Phil connects again. Let me see. Okay, so I'm going to give the floor to Dr. Shalini Desai. Dr. Desai is a medical officer within the Immunization, Vaccines, and Biologics Department at the World Health Organization. Dr. Desai has a background in pediatrics, infectious diseases, and public health, and she has worked in the field of immunization for many years, not only national, but globally also. So Dr. Desai will provide a presentation titled The Life Course Approach to Vaccination to Strengthen Health Policy and Achieve Better Health Outcomes. Please, Dr. Desai, go ahead.
Thank you so much for that kind introduction. And I'm delighted to be here today to speak at this webinar. I do have to smile because Dr. Philip mentioned that he's a pediatrician. I too am a pediatrician, so it's almost like I'm preparing for children as they continue to grow older, become adults and older adults. But anyways, the title of my talk is The Life Approach to Vaccination to Strengthen Health Policy and Achieve Better Health Outcomes. My objective over the next 10 to 15 minutes is to describe the practical considerations of the life course approach to be integrated into the existing EPI, or expanded programs on immunizations, and what does that mean for our programs? So let me start with the Immunization Agenda 2030. I think Dr. Vega alluded to this with his opening remarks. And so this was a global strategy for immunization for over the next decade. The World Health Assembly, along with partners, have endorsed this new global vision and strategy to address the challenges that we have related to immunization and hopefully to save many, many more lives than we already have with vaccines. And so the vision for this decade is a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. And so one may ask, what is it that we're going to get from having a life course approach to vaccination? And so this slide just shows what we hope to be able to accomplish. And so we hope to prevent death and disease across age groups. The examples that I've listed here include HPV in, let me just see if I can move this because I think that might be in the way. Okay, HPV in adolescents to prevent cervical cancer, maternal vaccination to protect both mothers and fetuses. COVID-19 vaccine in adults and older adults has been seen to have such a huge impact within this age group. It also reduces burden of disease by preventing diseases which allow individuals to live fully. So to maintain their functional capacity to work or go to school and participate in their communities. Also, vaccination has the highest rate of return of any public health intervention. The life course approach to vaccination also allows us to strengthen primary health care, to reduce the burden on primary care, and also offers an opportunity to invest in systems and service delivery. All of this is an integral part of IA 2030. And so what are some of the key considerations when transitioning to a life course approach to vaccination? I've listed out 7 here. In the interest of time, we're going to go through the top 4, and I've provided at the end of my presentation a number of resources which will include ways to build acceptance and demand, ensuring equitable access as well as financing and advocacy. So if we move to the first one, which is identifying and reaching target populations. So life course vaccinations recommend that we give vaccines at each specific stage of life. This figure is an example of vaccines that can be offered to different age groups. Some of you will see that, for example, for newborns, infants, the second year of life, as well as children, we're very well familiar with these vaccines. But when we start to think about what vaccines we can provide adolescents, adults, and older adults, these are less well known to us. Of course, with the pandemic of the last 2 years, and it's still ongoing, COVID-19 vaccination has changed much of that. It's allowed us to expand the vaccines available across the life course. And in many ways, it's accelerated our efforts to include all people, irrespective of age. The second key consideration that we'll consider today is integrating with other services. So our life course approach recommends specific vaccines at each stage of life. And for each of these stages, we have a delivery platform where health services can be integrated together and delivered to that specific age group. By treating each stage as a delivery platform, we're able to pair vaccination with other health interventions. And the hope is, as we do that, we can increase the efficiency of delivery of all of our services. This figure depicts opportunities for integration by providing people with the necessary interventions, including immunizations across the life course. What we'd like to see is this happen more, and with programs working together to deliver packages of services. IA 2030 puts a strong emphasis on a people-centered approach, and we need to ensure that people are receiving these interventions as they need. As a part of this, we'll be able to reduce missed opportunities and improve health service delivery and promote synergy between programs. Recording and tracking of data. What do we need? So this is an example of the COVID-19 dashboard. Many countries have developed similar dashboards, and some countries are planning to build these dashboards for other vaccine-preventable diseases and antigens. Consideration will also need to be given to data at a regional level and at a district level. Immunization registries can also be added to ensure vaccine-related data can be accessed by health providers. Home-based records are also needed for individuals to know what vaccines they have received and to know when they're eligible for additional ones. Catching up on missed vaccination. The final aspect we'll look at today is catch-up of missed vaccinations. The last three building blocks are also, of course, important. And as I mentioned, there are resources at the end of this presentation in order to help us with those. This slide shows the components needed for catch-up vaccination. If I could draw your attention first to the middle circle. So at the heart of all of this is having policies and schedules available. We then need to think about strategies to be able to deliver catch-up vaccination. We need vaccines and supplies for those catch-up vaccinations, and health workers need to know what the practice should be in order to help catch up individuals who may have missed a vaccination. Recording and reporting practices, as well as information systems and tools, need to be developed in order to allow all of these vaccines to be recorded within the systems. Communication and community engagement to build support so that people know that they can come to healthcare facilities in order to catch up on vaccines that they may have already missed. On the right-hand side of your screen, you can see there's a WHO table of recommendations for interrupted or delayed routine immunizations. And on the left-hand side of your screen is a guidance document that we've developed in order to allow for planning and implementation of catch-up vaccination. Finally, I'd like to just spend a few moments talking about the global status of life course vaccination. These data visualizations are done using 2019 JRF, or Joint Reporting Form, data. So data was collected through a routine Joint Reporting Form, which is an annual data collection tool that we use within the EPI program. Each of our data collection points were categorized according to one of the 7 life course stages. So pregnancy, newborn, infants, children, adolescents, adults, and older persons. Here we have an illustration of the status of life course vaccination by WHO region. What we see is that by region, the percentage of countries with universal vaccination recommendations for each life course stage varies. The red box shows the region of the Americas, where vaccinations for adolescents, adults, and older adults are less universal than those for childhood programs. In conclusion, all people across the life course should have the opportunity to benefit from vaccines. In order to realize this, we as a healthcare community need to work to ensure policies for vaccines occur across the life course. We must be able to identify and reach target groups, integrate our activities with other activities to improve reach, generate data and analyze it to strengthen programs and understand our impact, build in programs for catch-up of missed vaccinations, build acceptance and demand, and ensure equitable access. And finally, here are a number of resources on life course and integration that have been developed that hopefully will help as we work towards a life course vaccination. Thank you.
Thank you so much, Dr. Desai. Thank you for a very comprehensive presentation and also for sharing the resources. That is going to be very useful. I think we have Dr. Philip back. So Dr. Philip, we are going to share your presentation so you will have a better speed in your internet. Brenda, can you please share the presentation?
Thanks, Karina. Thank you so much. And apologies. If I can have the first slide, please. And once again, sincere apologies. When we try to connect long distance, at times these things will happen. Where I was starting is at the moment, thank you so much to PAHO for kindly inviting me. And I am a pediatrician and more of a neonatologist that start at this end of the life spectrum. So it is really interesting for me to talk about the whole life course. Can I have the second slide, please? So this is where that connection is between the baby and an older person. We in pediatrics are very used to vaccination. So if you could somehow transmit that information to older adults, our citizens who are adult citizens supposed to be more responsible and looking after their health, we could actually spread the message what we are well used in pediatrics to adult life and the whole life course. Next slide, please. This appeared on the front page of Time magazine a few years back, and it is scary on one side and interesting on the other, and that is a baby born at around a few years back in Western Europe could actually live to 142 years. Now, what should we take from that? From the perspective of life course is the responsibility for all of us to make sure that that life course is fruitful and without any illness. My job and that of my colleagues often is to look after babies of the right side who are extremely low birth weight. So our challenge may be even more to keep those citizens healthy throughout the life course. Next slide, please. So vaccination along the healthy life course improves quality of life, we know that, promotes well-being, and decreases morbidity with growing age. We know that, but the uptake is still not great. So could I have the next one, please? So it's like an umbrella, and it is covering all the age groups in the spectrum. And in addition to that, also pregnancy, immunocompromised, and so on. But at the crux of all these is healthcare professionals and their commitment and their interest to provide it and the systems to support it. Next one, please. So in addition to the overall life course, I would like to mention briefly why it is needed. What is immunosenescence? And the interesting term, what is inflammaging? And my area of real interest of maternal immunization to get the two-in-one in one go, herd immunity or community immunity, wider societal benefits, 5A and 4Cs and barriers, and next decade from PAHO. Next one, please. So in life course, we all know that the vaccination across different stages of life improves health and reduces the healthcare cost, promotes well-being and healthy aging, protects the community through herd immunity, or better term will be community immunity, and increase productivity and economic benefits. Next one, please. This was one of the cartoons we brought out in 2017-18 time life course as the gateway to health. The reality is children and their parents remember the immunization saga during childhood, but then we forget about it. In one sense, COVID helped the world to reorient adult immunization. So we have to use that opportunity to actually give a second thrust to life course immunization for other conditions, I think. Next one, please. So this is where we have to go from the child course to life course. Up to a few years back, immunization was almost like identified along with a child. And only a couple of immunizations were all what were used routinely in the adult life. But that also says that there is a massive amount of expertise created among pediatricians, community workers, public health nurses, general practitioners around the successful implementation of childhood immunization. So if we could convert or translate that to the adult immunization programs and other systems, we could actually spread the wings to the whole of life course. Next one, please. So a quarter of the European adults live with multiple chronic conditions. But the reality is that not even half of them are getting even a flu vaccine during the winter season. So awareness is there to some extent, but the application is still lagging behind. Next one, please. This is where I interact a lot with the excellence in pediatrics, advocating life force immunization to protect against vaccine preventable diseases. And I like the top, that pink area, mind the gap. It is a vaccination gap I think we have to fill. Next one, please. We could actually skip this one. It's already covered by Dr. Shalini. Thank you. I think we have a missed opportunity almost there. And if we do not want to miss it continuously, then we need a paradigm shift, because the lifespan increases, generally birth rate decreases, and that leads to world's population, which is aging. Now, more than 65 age group adults are more than children below 5 years of age. So the potential of life course immunization is to prevent the disease and to promote the health. We know that, but that is largely overlooked. Now I talk about a few specific aspects which I alluded to earlier, please. Next one. And PAHO is doing a lot in the spectrum of life course when we checked it, and there is a very clear pathway for the 2021-2030, the demographic shift and transition to the vaccination to the older people. And so if it is region-specific, cost-effective, and evidence-based solutions, then people might take it. Next one, please. One of my passion areas is the maternal vaccination, which is a part of the life course vaccination. And here the benefit is you have 2 generations, in fact, being helped by one immunization. There is no other scenario in vaccination where 2 generations could be simultaneously helped. And the time-old one where the baby is benefiting is the tetanus toxoid, whereas now the Tdap is there, including the pertussis. But in addition, there is influenza. And there is a multitude of vaccines, I think, hopefully will come over the coming years, including RSV, Group B streptococcus, and so on. Next one, please. So this is one we use in Ireland as an advertisement campaign to promote the life course vaccination for pregnant women, and that you can get the immunization either from your GP or from your pharmacist. And next one, please. But it is not easy as well. It is not without barriers. A lot of barriers exist when we talk about maternal immunization. Still, it is not great because the lack of recommendation by all healthcare professionals, low uptake despite official recommendations, lack of specific clinical trials, and many mothers may be worried about giving the vaccination. There's a lot to be done to actually move away the worries and to bring people along with and to take the life course and as a maternal vaccination option. Next one, please. The next aspect is, why is actually life course immunization needed? One of the fundamentals of the principle for old age or older age group immunization is the principle of immunosenescence, whereby there is a gradual decline of the immune function as the age advances. Thymic involution, decreased number of function of T and B cells, atrophy of the lymph glands, memory T cells may not be doing the job properly. Immune system is called disbalanced and resulting in a condition known as inflammaging, which is a combination of inflammation, susceptibility to infection along with aging. This is where we have to either limit or reverse to get the better outcome. Next one, please. It looks very complex, but all it says is there is a reduction in the neutrophils and natural killer cells, monocytes, macrophages, function of T and B lymphocytes come down. All of these, along with other age-related scenarios like autophagy, gut microbiota changing, dysbiosis, all pulled together will result in inflammaging. And that could be, that along with the immunosenescence of the cellular level, make the host susceptible to infections again, even though they had some protection during childhood, that may not be enough. Next one, please. So when you look at the life course on one side, you have to do a remodeling through healthy lifestyle, nutrition, and appropriate immunization. We can actually move to the right, to the green zone of a remodeling of immune adaptation. So life course vaccination is playing an important role and an important component in the life course of various methods we follow. Next one, please. The next element is while we are doing it, there is also a herd immunity or community immunity. When the sufficient number of people are protected, it may be making the protection for those who are vulnerable, who could not take it or who could not get it for various reasons. There are many, many examples of herd immunity, and people started hearing about herd immunity again during the COVID season. But at the same time, this is something to be kept in mind as part of the life course immunization as well. This is a beautiful slide, a bit crowded, but it sends the message as a picture that the susceptible are protected when sufficient number are immunized, not only among children, but also among older adults. And there is an important area which is often under-mentioned or undervalued is the antimicrobial resistance and the value of life course immunization. WHO is considering antimicrobial resistance as one of the biggest threat of humanity. If that is the case, one of the major help for humanity to counterbalance that would be optimization of the life course immunization. This we brought out a few years back in one of our articles about the maternal vaccination. But I think it is equally applicable to life course immunization. Just by saying it, it will not happen. You need access, awareness, affordability, acceptance, and very important, linking all of it together, activation. And next one, please. Next one again, please. And we could go one more level. That's the one we were talking about, the activation, access, awareness, affordability, and acceptance. Without these key components, it's very difficult for any idea to become a true successful vaccination program. Next one, please. And that also will bring us nicely to what I call as the 4C concept. That is, we have to, as the healthcare professionals and organizations, cross-culturally and cross-country even, we have to bring and enhance the confidence, improve the convenience, remove the complacency. And a new one we could add on to that paradigm would be the mindful of the cultural acceptance. And otherwise, these things will be just on the paper, but may not progress much beyond that. Next one, please. This is one of the points in Lancet recently about the COVID and how it brought out the idea of the life course vaccination again for adult population. It is so important to cash on that opportunity. Next one, please. Like anything else, a novel idea like life course may not be without the barriers at a different levels, at physician level, schedules, population, national bodies, ideological side, mindset. Many of us may go travel abroad and take a vaccine, but not at home. Access, government policies, and still the anti-vaccine lobbies may be even functioning very effectively. So we should be mindful of that. So there are so many barriers, but together we could counter it or bring it down to a great extent. Next one, please. And the success of the life course immunization for the next decade could be based on the working in synergy with other health programs, integrated with wider health systems. Resources should be used efficiently, equitable access should be there. And another thing Dr. Shalini mentioned earlier about the catch-up programs and for the missed doses, and to ensure the people-centered delivery with the cultural acceptance. Next one, please. I hope some of the things I wanted to communicate, I could communicate to some extent, but as the famous quote says, the problem with communication is the illusion that it happened. Hope I communicated some of our messages from here to you. And once again, thank you so much for giving us the opportunity to share some of our thoughts with all of you.
Thank you so much, Dr. Roy. Very, very good presentation. And your presentation and Dr. Desai presentation really linked together. Very informative. Thank you so much. El siguiente segmento de panelistas, contaremos
The
con la
next segment of panelists will have 3 presenters, which will focus in the life course perspective for immunization. The first panelist is Dr. Flor Munoz Rivas, specialist of pediatrics diseases and respiratory diseases and epidemiology. She's currently assistant professor of pediatrics at the Baylor College of Medicine and medical director of infectious diseases transplants at the Texas Children's Hospital. She will make a presentation about the importance of the high vaccination coverage. After, we will have Dr. Francisco Novareda, who will make a presentation of vaccination timing and applying the life principles to improve health over lifetime. He is an epidemiologist with more than 15 years of experience in immunization and infectious diseases. She has been working for many years at the WHO, including vaccination against cholera, polio, hepatitis, influenza, and COVID-19. In 2020, he joined the immunization unit of PAHO, and now he is the regional focus point for influenza vaccinations, and he also coordinates the REVELAC-I network for the evaluation of the effectiveness of influenza vaccine in Latin America and the Caribbean. And then Dr. Laia Bruni, a shot to prevent cancer cumulative impact of HPV immunization. She's a specialist in preventive medicine and chief of unit of the cancer epidemiology at the Catalan Institute of Oncology in Barcelona, Spain. And for more than 10 years, he has been coordinating the HPV Information Center and Cancer and VPH, HPV vaccination and cervical screening. And at the national level, she coordinates the organization of the new early detection program of cervical cancer in Catalonia, together with the assessment and monitoring of the cervical impact, screening impact. And finally, Dr. Daniel Salas, Unit Chief of the Comprehensive Family Immunization Unit, who will close this webinar. And now I would like to invite Dr. Munoz Rivas to make her presentation. Dr. Flo, the floor is yours. Thank you very much. Good morning, good afternoon, good evening, wherever you are. I will start sharing my screen. Can you see me? The slides will be some in English, but I will speak and I'll present in Spanish. I am an associate teacher in pediatrics and molecular virology at the Baylor College of Medicine here at Houston, and I have been working for many years in vaccine preventable respiratory diseases, and these are my potential conflicts because I continue doing research and participating in safety committees for different vaccines, and specifically also for children and pregnant women. The topic I would like to address today is the continuity in the care and immunization, with a focus on children and a couple of diseases that illustrate the importance of this link. I will start with an observation about child mortality as an indicator of health. About 1 of 5 deaths on a global basis are provoked by NCDs. And what I want to say is that many of these disease causes, especially in children below 5 years of age at the global level, have to do with infectious diseases. The first pneumonia, then diarrheal diseases, then malaria, bacterial diseases, neonatal sepsis and meningitis, whooping cough and measles and others. This is very important because if you realize that under 5 mortality is very high, up to 2020, it was estimated that more than 5 million children died before reaching their first birthday, and almost half of those deaths occurred among newborns, among the first month of life. 2.4 million newborns die by diseases that are often preventable. So the health of the mother has a good impact in the life of the newborn. This is very important, our linked lives by this interaction between the mother and her newborn, her fetus, and then her baby. And maternal health is a key determinant for infant health. We know that this occurs through a natural process in the placenta, where there's an exchange of antibodies and ICG. The mother transfers all those antibodies to her infant. And then during the breastfeeding, she transmits an essential protection to her baby in his first or her first months of life. So we have different opportunities for intervention and promotion of health between mother and newborn, first during the pregnancy, then during infancy, and then having groups of mothers and children together. So we apply this for infant immunization strategies. As we indicate here at the right, there's a table of recommended child and adolescent immunization schedules for ages each year or younger in the United States. Vaccination starts around the 2 months of age, and most babies don't have an immune response, but most have a good response because they inherited antibodies from their mother. On the left, we see that the response will be very high if the mother has high antibodies that transmits to the fetus through the placenta. And then as those antibodies go down, the risk of the immunological risk of newborns increase. So we need to protect them when those maternal antibodies no longer protect them. And you can see how this basic interaction and basic knowledge of the mother-child immunity allows us to have very clear and specific interventions such as vaccination. This illustrates the continuum between maternal immunization and infant immunization and maternal infant health. We have a healthy mother and we can protect her with increased levels of antibodies so that they transmit them to the children, and that susceptibility zone where the child depends on those antibodies while the child is not yet vaccinated. But then, because the first 3 months is truly for childhood vaccine. So this is very fundamental for the perinatal and prenatal care of the pregnant mother, and then post-natal care of the baby in the first months of life. So this is very clear. It's an intervention that works. It is well established, both the maternal vaccination and the child vaccination. Here, I show the WHO position of vaccines in pregnant women. In general, tetanus and diphtheria and inactivated influenza vaccine and also pertussis vaccines. These recommendations are based in a risk-benefit stance and the risk of the low risk of disease from the vaccines. We see vaccines that are with live viruses and other vaccines that are recommended in special situations, such as right now the SARS-CoV-2 vaccination when there are outbreaks. And right now after the pandemic, we are in a quite difficult situation. Here we have the vaccination coverage of different regions at a global level. These are WHO estimates for 2021, and one of the basic vaccines for children is DTP3, 3 doses of DTP. And what we see in orange and pink and the 80 circled, that in 2021, during the pandemic, there was a reduction of the effectiveness of this DTP that went down to 80% during the pandemic. This is very important because there are a million children, more than 2.7 million children of under 1 year of age in the Americas, 19.7% that have not received the DTP vaccine. The case of here in whooping cough, we had advanced in the Americas, but DTAP was recommended for pregnant women in addition to vaccinations of children and adolescents. And we have had great success, but currently countries that vaccinate with pertussis vaccine to pregnant mothers, there's no mortality or disease in their children. We have practically eliminated mortality among children, but in 2021, there was still more than 6,000 cases of whooping cough reported. This was the situation prior to the 2012 recommendation in the US. And this reflects what we have seen at the regional level, gradual increase up to 2012 and then a reduction. We don't want to go back to the situation of decades before without vaccination of mothers and children. Those were the red bars of deaths by whooping cough because the vaccine had not been administered. This is just to say that since we started using vaccines, there has been a 95% of prevention of deaths by whooping cough. cough when we instituted the vaccination. We need to continue promoting this. And then I want to illustrate the case of measles, because the low coverage, measles makes us very susceptible if there's no adequate coverage of immunization. Even though mothers are vaccinated against measles when they are girls, their antibodies in maternal vaccination is lost more quickly than the immunity acquired by natural disease. This graph at the left shows the loss of immunity in newborns in the ICG, the antibody coming from the mother. If the mother is vaccinated, there are lower levels of antibodies when she gives birth. We are at risk if we don't vaccinate the mothers, but if we don't vaccinate children, they may lose quickly the immunity transmitted by their mothers if the mothers have not been vaccinated against measles. These are the WHO estimates for 2021. Coverage, one doses was 84%, first dose, and second 75% just for the second doses. And there has been an increase in the reported cases, and we are at risk in many countries. Here we show WHO cover data for different countries. If there's less than 95% coverage of vaccination, we are at risk of measles outbreaks, because then the children will not be vaccine protected. And we are at a critical juncture now. We are seeing it. You know that measles was in the process of being eliminated, or there were plans, because there was a great increase in the measles vaccination for children. And we can see here the number of cases that can occur by measles that can be fatal at some time. But in the dark line in the low part of the graph, in the absence of vaccination, the cases would increase. In the decade between 2000 and 2017, more than one decade, 21.1 million measles deaths were averted globally. But this, we are at risk of seeing an increase if we don't increase vaccination. But we are a society, a very mobile society and community with great risk. This graph shows that if we don't get vaccinated anywhere in the world where there can be a measles outbreak, this can be transmitted quickly to other countries and put at risk many people, especially children. Thank you for your attention. Thank you very much, Dr. Flor. Excellent presentation. All presentations so far have been of great quality and very informative. Now, I would like to invite Dr. Francisco Nogareda for his presentation. Thank you very much. I will share my presentation. Good morning, everybody. Good afternoon. I'm Francisco Nogareda. I work at PAHO, and I'm the focal point for influenza vaccine. And I thank you for the opportunity to participate at this webinar. I will talk today about the vaccination of influenza vaccination timing to improve health over the life course. I will talk, first of all, generically about the influenza virus and the influenza vaccination, then the seasonality and the timing in the vaccination, and the importance of vaccination, of the early vaccination before the start of the influenza season. And then I'll talk about the risk reduction impact and mitigation of the disease thanks to vaccination. The influenza virus is a respiratory virus transmitted mainly by droplets and aerosols coming from respiratory secretions from infected people. There are 4 types of influenza virus. The A virus A and B are the most significant. These viruses cause seasonal epidemics in temperate zones, and also with higher outbreaks in subtropical and tropical zones. Influenza A viruses have a pandemic potential. They can trigger pandemics given major antigenic changes that have the capability of a sustained transmission from person to person. Let's think, for example, our influenza A pandemic we had in 2009 with the H1N1 virus. The clinical presentation can go from an asymptomatic infection up to a serious disease. For example, pneumonia, myocarditis, encephalitis, sepsis, and even death. As to the influenza disease burden, it is estimated that every year in the world about 1 billion people contract influenza. 3 to 5 million have a serious case, and 290,000 to 650,000 deaths, a fatality of 0.1% to 0.2%. In the region of the Americas, there have been 772,000 hospitalizations and 52,000 annual deaths associated to influenza. This is a high disease burden for the countries. As to the seasonal influenza vaccine, it's a safe and effective vaccine which has been used safely since the 1940s. And since 1977, it has the trivalent vaccine with 3 virus strains: influenza A, H1N1, influenza A, H3N2, and influenza B, the Yamagata or Victoria lineage. And we also have tetravalent vaccines with both lineages since 2013 or 2014. Given the antigenic changes each year, the vaccine is updated depending on the strains. The vaccine is updated, its composition is adjusted, it's reviewed twice yearly by experts, once in February in the northern hemisphere and one in September for the southern hemisphere. The main objectives of influenza vaccination. One is to reduce the influenza-related mortality and morbidity, and to mitigate the seriousness of this disease and reduce its sequels. And even those who have had serious cases of influenza can benefit from the vaccination. And a second objective is to interrupt or at least limit the virus transmission.
From these 2 objectives, the group of experts on strategic counseling of the WHO has defined 5 priority groups for vaccination based on the criteria of the groups with the highest risk of developing a serious disease and the greatest exposure or transmission of the virus. As those of the greatest risk of developing a serious disease, we have the older adults, mainly after the age of 60, those with chronic diseases, pregnant women, and children from 6 months to 5 years of age. And as those of greater risk of exposure and transmission of the virus, it would be the health professionals. I must add that children play an important role in the transmission of the virus. In the Americas, there are data from 2021 from 39 countries with influenza vaccination policies, 87%. The same countries are vaccinating the health workers, 82% of persons with chronic diseases, 76% of older adults, 73% of pregnant women, and 67% of children. As for the seasonality, we see here the circulation of the flu virus by subregion for the period of 2015 to 2022. On the top part of the figure, we see the region of North America, the Northern Hemisphere, and we see the circulation of the flu virus following a seasonal pattern with peaks occurring yearly around the month of January and February, usually. After 2020, we see a drastic drop in the flu circulation, which is when the COVID pandemic appeared. And we see that at the end of 2021, there's been a re-outbreak of the flu circulation, though much lower levels than the ones in the past. If we go to the last subregion of the Southern Cone, Brazil and the Southern Cone, we also see the same seasonality pattern, but we see that the peaks of greatest incidence occur mainly during June to August, which are the summer season. And it follows the same seasonality pattern. There's a practically nil circulation during the pandemic, and then a large outbreak again in 2021. In the Caribbean region and in Central America and the Andean region, which are tropical or subtropical regions, we see that there is no clear seasonality pattern. There are cases occurring throughout the year, and it's really difficult to predict the seasons in these three regions. Here, I try to show one of the countries, in this case, Chile, showing the I'm sorry, I couldn't hear. His sound is really very low. It's difficult to hear some of the things he says. This is the flu in the last 9 seasons, and we see that the season would begin in the yellow line, which is the threshold period, which would start around the week 18 or 20, where the peaks are reached between the week 22 to 35, and then the low season would end around week 43 to 50. If we do average curves of these last 9 seasons, and we get a mean curve, this is the type of curve we'd get. And we see the yellow line is the epidemic threshold, and we see that the flu season in Chile, based on these last 9 years, would begin on week 18 and end week 40. So that would be the epidemic period, the period of greatest exposure to the flu virus in Chile in the Southern Cone. And then we have a critical period, which is very high circulation, which is when the influenza virus has a very high intensity, which would be between the weeks 25 and 38. As I say, this is an average. There may be some seasons where it might be earlier or later. This is just an estimate. The vaccination must begin before the beginning of the epidemic period. The more susceptible should be vaccinated before they cross this yellow line, which is the threshold to avoid being exposed and reduce the risk of serious disease. As I said, the vaccination timing should be done ideally before the epidemic period begins, with the hope of reducing the risk of serious diseases and death during the flu season, especially the people with greater vulnerability or who may develop greater complications, and especially when there's a period of greatest circulation of the virus. We've also seen the impact where the vaccination if the impact of the vaccination is greater when you reach high coverage as well as soon. And I'll show an exercise that we did here in Paraguay to confirm that information in older adults between 2013 and 2018. In this table, we see the number of cases, medical visits, hospitalizations avoided during the vaccination or thanks to the vaccination. We have the coverage data here, and we see for example, here 36%, which is the coverage reported by Paraguay in this group of older adults. And we see that thanks to the vaccination with this coverage, which is relatively low, 23,000 cases have been avoided, 10,000 medical visits, as well as 390 hospitalizations have been avoided. If we increase the coverage, 50%, we also see an increase in the number of cases, medical visits, and hospitalizations are reduced. And the same, if we were able to reach a 90% of coverage in this vulnerable group, the number of cases, medical visits, and hospitalizations avoided would be much higher. Aside from coverage, we've also noticed the time of the vaccination also has an impact. We used 36% coverage reported by Paraguay, and we attempted two simulations, one for 3 months with a vaccination campaign that lasted 3 months, and a faster one that lasted 2 months. And we see that the 2 months campaign had a number of cases avoided, medical visits, and hospitalizations. It was much greater than the campaign that lasted an extra month. We concluded that the effectiveness and impact of the vaccines is much greater when you reach greater coverage, as well as when the campaign takes a shorter period of time. The effectiveness of the flu vaccine reduces the risk for a given result. It could be infection, hospitalization, or even death. This effectiveness varies by season. As I've said, it all depends on the type of strain circulating, as well as two other factors, which is the consistency of the circulating strains during the season, as well as the strains used to prepare the vaccine. And the effectiveness also depends on the characteristics themselves of the persons that are being vaccinated. We know that the vaccine effectiveness is less in the older adults due to the immunosenescence and people with comorbidities like immunosuppression or immunocompromised diabetes or others. In any case, the flu vaccine significantly reduces the risk of developing a serious disease. In the immunization unit of PAHO, we've been doing effectiveness analysis every year, and we monitor the performance of the flu vaccines in the Southern Cone with the Revelac project. This is the data we've obtained in recent years from 2013 to 2018 in the older adults. And we notice that the vaccine effectiveness varies each season, 48%, 50%. It drops to 23% in 2015. It goes up to 42, 19, 47. And the overall for the whole period was 37%. So in general, one could say that the effectiveness or the reduction of the risk of hospitalization due to flu is lower in those seasons where there's the H13 virus is prevailing. And lastly, the mitigation of the severity in vaccinated persons. We've also done a study in hospitalized patients due to influenza in Argentina, Brazil, Chile, and Paraguay for a period of 2013 to 2019, and have seen that the persons vaccinated against the flu remain in the hospital a significantly lower period of time, with less probability of entering the ICU and less risk of hospital mortality compared to those who were not vaccinated. And here you have the article published last month, in fact. And to conclude, every year during the flu season, the most vulnerable people are exposed to the flu virus and could have a serious disease, which could alter or cause changes in the health trajectory. Vaccination is a key and essential strategy to prevent the disease, the flu, particularly the severe forms in older adults, in persons with pre-existing diseases, and in pregnant women. Vaccination should be done in a timely manner, as we've explained, before the epidemic period begins, where there's a greater circulation of the virus and greater exposure to the disease, and annually to ensure optimum effectiveness of the vaccines. Thank you very much. That's all. And I'd like to thank the colleagues like Daniel Sala, head of the unit, Marta Velandia, Marcela Contreras, Margarita Giselli, and my colleagues from PHE and PAHO, Paula Cota, Angela Rodriguez, Julia Leite, and as well the CDC colleagues, Eduardo Assis and Ashley Fowles. Thank you very much. Francisco, thank you so much for your presentation. That was an excellent amount of information. And now I would like to give the floor to Dr. Laia Bruni, who will talk to us about a vaccine to prevent cancer, cumulative impact of immunization against BPA. Thank you very much. I'm going to put up my presentation.
Muy bien, bueno, muchísimas gracias por la invitación. Es un placer poder
Thank you for the invitation. It's a pleasure to be here today in this seminar talking about immunization from the point of view of the life course approach and the HPV immunization with cancer or cervical cancer prevention. In the case of the HPV vaccination, we have interventions where we vaccinate at an early age, usually between 9 and 14 years of age, to prevent disease not during those years, during the adolescence, but one that could arise later on during the adult stages. In the HPV, there's a very important gap between the intervention, the vaccination, in other words, and the clinical event we are trying to avoid. And it is characterized with critical periods, sensitive periods, which are very large. The life course approach is key to prevent cervical cancer, and that's why I shall begin describing first a bit of the natural history of the disease, the determining factors which in the end are key to optimize the vaccination strategies. The papillomavirus are ubiquitous in skin and mucosa, and they're transmitted usually through direct contact. In most cases, the disease occurs asymptomatically, but the HPV can also cause hyperproliferative diseases, which can be either benign, like the skin warts, or malignant, which is the disease that we're talking about today, which is cervical cancer, as well as other cancers related to HPV. There are more than 200 HPVs identified, and one could divide them of whether there's mucosal or cutaneous tropism. But today we're going to talk specifically of the mucosal tropisms affecting the mucosa, and of them, a subgroup, which are the ones we call high risk or carcinogens, which are these that we can and seek to prevent with the vaccination. The HPV of mucosal tropism are of sexual transmission usually, and in a lesser degree, vertically transmitted through secretions of the birth canal. Very frequent secretions. Most of the population is exposed at some point in their life. The statistics say that more than 80% of men and women sexually active can be exposed to HPV before the age of 45. As we've said, most of these infections tend to be asymptomatic without any type of clinical manifestations, and resolve spontaneously and are not recognized without any results or consequences. However, that 10% of infections that are not resolved spontaneously, which are the ones we call persistent infections, are in this subgroup where we have the risk of the progression to cancer during the life course. These VPH are carcinogens and can cause either cervical cancer, which is the most frequent, and that's why we talk about prevention of cervical cancer affecting women. But the HPV is also related to the cancers from other anal and genital locations like vulva, vagina, anus affecting men, as well as in the head and neck.
We also have, and I also include them here because they are also included in the vaccines, we have what we call the low-risk HPVs that provoke genital warts but have a high degree of mobility, such as condyloma, and also the recurrent respiratory papillomatosis, which is unfortunately very strange, very rare occurring. This is a case where here the method of prevention would be to vaccinate mothers and thereby protect their children, not through the antibody transmission, which also help, but preventing infection of mothers. And when they give birth, the birth canal secretions will not infect their baby. But there are also other aspects that also benefit from the vaccine. Currently, we basically have 3 formulations of vaccines against HPV. The first one that were marketed were the bivalent and polyvalent. Both types include types 16 and 18 that are the most carcinogenic. The 9V HPV vaccine that came later to the market added the protection for other 5 types that are also carcinogenic and raised the protection to almost 90% of cases of cervical cancer. As I also said, the tetravalent and the 9-valent vaccination include the protection also to type 16 and 18 that are responsible for genital warts, among other manifestations. How does this translate at the population level? This would be the prevalence pattern of infection over the life course. Since this is a sexually transmitted disease, and this is very important, it is what has determined the vaccination strategies. The peak of infection starts around 15 years of age when girls become sexually active, and since it's such an ubiquitous infection, there's an infection peak at the population level, which happens around 20 years of age. And after the exposure and the acquisition of natural immunity, this peak goes down and then it plateaus at around 30 years of age. And in some countries, this has also been related to immunosenescence, and there's a flare-up of these diseases acquired at a young age. But these infections are persistent if they were contracted at an early age. But other people can contract these infections later in life. What are the known factors for the infection? All that has to do with sexual conduct. The earlier the sexual initiation, the higher the risk of infection, and this is totally related with the number of sexual partners. The more sexual partners, the higher the risk of infection. But also in the case of women, there's an important factor with a partner. In the case, can be a male partner, and the woman can be totally monogamous, but if her sexual partner is not monogamous, she acquires the risk transmitted by her partner. Depending on the population, we have different patterns of sexual conduct that change a lot. These curves can happen earlier or later, depending on the sexual initiation. It can move to the left of the graph, the initiation curve, or it can be quite marked, the peak at around 20 years of age, depending on the number of concurrent sexual partners. And then, as I already mentioned, there's a plateauing later in later ages with the acquisition of immunity, and this can vary a little also depending on the different characteristics of populations, and the screening also has an influence, because if you are detecting lesions, you're looking at prevalent infections. So this is also a behavioral factor. We saw that we have the first peak of infection. Most of infections are resolved, but the small fraction that is not resolved, some of them will go to a precancerous stage 5, 10, 15 years after the infection, and starting at 30 years of age, we see the greatest incidence of precancerous infections. And then we would have a fraction of these precancerous lesions that have a risk and then go to develop an invasive cancer. And depending on the progression, the HPV type is a determinant factor. That type 16 and 18 are the most cancer provoking, but others are not as aggressive as type 16. But we also have other cofactors such as high parity, oral contraceptives, smoking, and also co-infection with HIV. All of these are concurrent factors, but as we can see, cervical cancer is the last stage of an unresolved infection acquired early in life. What do we do with HPV vaccination? The main idea or strategy that is where all efforts are focused. The idea is to vaccinate before the peak. If we vaccinate, there will be no risk of infection and no later cancer. We have also screening that in those women who have not been vaccinated or have acquired infections not covered by vaccines, we detect this precancerous lesion, we treat it, and then we cut the progression between precancerous infection to a cancer stage. So we have a combination of two strategies. And beyond the natural story and the most biological factors, I also want to say that these are data from Colombia, but this is seen all over the world. Cervical cancer is clearly a cancer affected by social inequality. The most at risk, the most disadvantaged groups have 10 times more risk of dying by cervical cancer. And the lower the educational level, the higher the cervical cancer mortality. This gap is not reduced with screening. Universal vaccination is a great opportunity to address this problem and to bridge this socioeconomic gap to protect equally the entire population with no access barriers to vaccine. We already have real data about the impact of vaccination programs in the northern countries of Europe that show not only the benefit of vaccinating at the ages that we mentioned, between 9 and 14 years of age, but also during adolescence. The benefit is not as large, all depends on the exposure to the virus and depends on the level of sexual activity, but data from Sweden already shows that the cohorts that have been vaccinated before 17 years of age have seen an 88% reduction in cervical cancer and about 50 or 53% reduction when vaccinated before 30 years. And then we see data from Denmark, clearly similar data to those of Sweden, when vaccination was administered before 16 years of age, and that produced an 86% decrease in the incidence of cervical cancer among women vaccinated before 16 years of age. And if they were vaccinated between 17 and 19 years of age, the decrease was of 68%. Later in age, no immediate effect in protection because of the lack of follow-up. We still don't know whether these two curves will be separating more and more. This shows, these are also data from the United Kingdom. And we see the same percentages, the same patterns, and also for precancerous lesions, the same level, what we detected in the screening. This is to summarize, and in the interest of time, I simply want to show the new recommendations that will come out of the SAGE, or that have come out of the SAGE. And there's a discussion about the benefit and the protection of administering simply a single dose of HPV vaccine, and the different vaccination strategies have different outcomes. The primary target are girls 19 to 14 years old, but there are also other populations that would benefit. There's a prioritization when you introduce a vaccination in a country for an extended catch-up with vaccination up to 18 years of age, and the possibility of vaccine or prioritizing vaccination of high-risk groups such as HIV and sexually abused individuals. Also, there's the issue of vaccinating boys. The HPV vaccine has also been highly protective. And introducing the vaccination of boys and older females should be carefully managed until the global supply situation is fully unconstrained. But vaccinating simply girls also protects their male partners, and this could eliminate the circulation of these viruses. All of these strategies are under discussion. There's a supply problem at the global level, and up to now, the message has to be to prioritize girls who are those who benefit most from the vaccination. But when the supply problem will be overcome, we will also be able to start messaging an increase of vaccination to continue the doses and open up the opportunity of vaccination beyond these cohorts. And at the end, we have a global strategy to eliminate cervical cancer with 3 objectives or pillars: to 90% of girls fully vaccinated with HPV vaccine by age 15 years by 2030, to have screened 70% of women and 90% of women identified with cervical cancer. And I would like to indicate in this aspect, how do we combine different interventions or along the life course to prevent and eliminate cervical cancer. This is a slide which is already old, but that shows this life course perspective, and that is part of the prevention of cervical cancer from the beginning. Here we see the natural story of prevalence and incidence curves depending on the age, and how we have different outcomes or different strategies depending the timing. And which is under discussion now also, is that beyond vaccinating girls in pre-adolescence and during adolescence at the academic level, but also we are trying to see whether we can combine different vaccination strategies. And now, to end the situation in the region, this is a map of the vaccine introduction based on the latest data. 65% of WHO member countries have introduced vaccines, and the Americas region has always been a leader in the HPV vaccination. 90% of countries in the region have already introduced this vaccine, but at the coverage level, even though the region of the Americas is one of the that has one of the best coverages for HPV. In the case of HPV, its coverage is mediocre, and we cannot attain the 90% of target coverage.
The last dates of the COVID vaccine, we've seen that it's gone from pretty high vaccination levels, not prior to the pandemic, for one dosage, and for the first full regimen, we're around 60–70%. And post-COVID, there's been a tremendous impact with a drop to global coverage in the region of 51% and 38% with the complete regimen. As the mean, the countries for one dose, the mean coverage of the programs is about 40%. But there's a lot of difference. There's a great variability between countries. There's some that vaccinate very well and are probably at 70 or 80%, and there are others that are at maybe 20 or even 10% vaccination. And with regard to this, the Americas region with the HPV vaccine is an example worldwide. Everybody looks towards us to see what PAHO is doing. But COVID has had a significant impact. The HPV vaccine has always required a special push. It doesn't behave the same as other immunizations. It requires a different type of communication and different communication strategies. And what we see is the importance of catching up. With the HPV vaccine, we don't have to focus exclusively because there's always a possibility of being vaccinated. I don't know whether there are resources to leave the door open to vaccination, even if it's beyond the 15 years, and even if it's with only a single dose. But what's important, and the work that's being done in the region to report coverages, high quality and high coverage. This is all very important in order to continue to monitor what's happening and to behave accordingly. Thank you very much. Thank you very much, Dr. Bruni. That was an excellent presentation. And I think that we're late already, and I would thank all the speakers for their excellent presentations and detailed presentations, particularly highlighting the importance of vaccination to build capacity in health throughout the life course. And now to end, I'd like to invite Dr. Salas, head of the immunization unit of PAHO, to give us some thoughts regarding these issues. Thank you very much. It is a pleasure to say the closing remarks in a very interesting activity like this, and sharing that immunization and vaccines are a comprehensive part of life and are with us starting at birth and even before birth, with the antibodies that are transferred from the mother to the child, and which many are in fact acquired through vaccines. And in the end, we see that they are with us throughout our life course. They're a very important ally to get better quality of life and better opportunities in life. So I think that these presentations from the experts were very useful to understand that applicability of the concept of life course approach in immunization. And undoubtedly, the speakers gave us very important examples of the application of the immunization, the benefits of the approach in the short, medium, and long term. The concept of immunization in the life course approach recognizes that the individual is influenced by a wide range of factors. Dr. Roy Phillips today gave us a general vision of immunization as a gateway to health throughout life, highlighting that if we don't want to lose the opportunity, we need that paradigm change of immunizations. He stressed that vaccinations during the life course must be a basis for the health systems as the spinal cord of this. In all health services in the region of the Americas, we live in a context of change and demographic transition, with aging in a context of diversity and inequalities. And we have to think of pro-equity strategies. The question of equity was mentioned by several of the speakers, and we have to take that very much into consideration when we consider immunization and life course. Also, he spoke of the key issues for a vaccination period. He talked about access, awareness, equity, acceptability, and the way in which the health professionals must include. I know they can, but from the point of view of health professionals, those of us working in health in any way have a vocation of service to protect and improve the health conditions and the life conditions of a person. Not only can, but he must include the acceptance of vaccines in adults using the 4 C's we talked about of improving convenience, trust, eliminating complacency, and being aware of the cultural acceptance. The 4 C's in Spanish. Dr. Salinas from the World Health Organization spoke of the life course approach helping strengthen health policies, making good use of investments in the health systems to generate an impact throughout society. And here I'd like to highlight the key considerations when doing the transition from the life cycle approach to vaccination, identifying target populations. It's true that vaccinations have been created practically for the infant population, but we have changed this, and the vaccination opportunities have changed, and the immunization at the young ages is with us all the time, but now it's including other population groups that are very important as well. She also said that it was important to reach all the population, supporting sustainable financing to maximize the health of the populations, integrating vaccination with other health services. If we think that there are possibilities and that sometimes we lose sight of them, of children who go through the health services, who have incomplete regimens and could have taken advantage of that moment. But since it's not the vaccination service or primary care service, they did not take advantage of the person being there. And she said of the need to use more integrating strategies, and maybe, if we could say it, more ambitious vaccination strategies. In the section of the panel, the expert spoke of the importance of immunization throughout the life course. Dr. Munoz Rivas gave us very practical examples of how immunity goes from one generation to the other. And since our lives are all linked using the maternal vaccination that she spoke of at the beginning, and that the benefits transmitted to the newborn are felt even from the very first months of life, and that for all of us throughout our life course, we must work on immunization using the example, for example, of the pertussis and measles vaccines. The epidemiologist Francisco Nogareda gave us even more information about how timing is so important. And the critical time is so important, not only to prevent the disease, but to create the specific immunity offering protection long run. And highlighted the fact that the flu vaccine had to be used in a timely manner in different groups, especially where the immunity must be reinforced before the flu season in an annual manner to reduce the risk of hospitalization and possible sequelas that could affect individuals in the next stages of life. And lastly, we heard Dr. Laia Bruni, an excellent presentation about the cumulative effect of immunization and the positive effects and long-lasting effects that can be felt after the intervention. And she gave the example of the HPV vaccine, highlighting the benefits of the vaccines, not only preventing cases of cancer, she also spoke of avoiding other diseases and reducing the inequality gaps. Speaking about the possibility of expanding this to other target populations based on recent investigations and information obtained from the stage, and the fact that the life course approach is part of prevention and approach of cervical cancer, without mentioning the fact that though the region is leading in the number of cases that have introduced this vaccine, we still have a long task ahead of us to improve the vaccination coverages to achieve the greatest possible impact. So it has been a crusade of very interesting presentations, very rich presentations. My gratitude to all the speakers for their participation, and my gratitude to those of you who have joined us to hear these. And we hope that this workshop, as Carolina said, be an opportunity for you to expand your knowledge and the discussion and an exchange of experiences so that you can positively contribute to continue with these actions to promote safe immunization with a better opportunity for all, for better health. Thank you all very much, and I hope you have a wonderful rest of your day.
Gracias.
Thank you,
Buenas tardes.
and good afternoon to all of you.
Thank you.